This is TTT Live. I'm Mahalia Joseph Wharton. The Ministry of Health is giving an update on the status of COVID-19 in Trinidad and Tobago. We're bringing you live coverage on TTT, Talk City 91.1 FM, and on Facebook at TTT Live Online. We go now to Senior Corporate Communications Officer at the Ministry of Health, Al Alexander.
Good morning, and thank you for joining us for another Ministry of Health virtual media conference. We are very pleased to have you join us, and through these conferences, we allow you, the public, to hear directly from the subject matter experts themselves. We remain committed to providing you with relevant, accurate, and up-to-date information on the COVID-19 response. Our panelists today are Dr. Avery Hines, Technical Director, Epidemiology Division, Ministry of Health; Roshan Siram Singh, Geographic Information Systems Manager, Epidemiology Division; Nurse Grace Sukchan, Manager, Expanded Program on Immunization; and Dr. Khatija Khan, Clinical Psychologist, Faculty of Medical Sciences, UWI, and a member of the UE COVID-19 Task Force. I am Al Alexander, Senior Corporate Communications Officer at the Ministry of Health, and your moderator this morning. We begin with Dr. Hines, who will present the clinical and epidemiological updates. Dr. Hines.
Thank you, Mr. Alexander. Good morning to my colleagues, Ms. Sukchand, Mr. Siram Singh, Dr. Khan. And good morning to members of the media, members of the viewing and listening public. Let me have my first slide, please. The clinical update for today, which reflects data as at the 25th of April 2021, is as follows. At both public and private facilities at that time, we would have vaccinated we would have tested 125,168 individuals, with 58,216 of those tests being done at private facilities. Out of those tests, 9,676 persons would have tested positive, and there would be 8,173 recovered persons at this time, and 1,343 total active positive cases. The number of fatalities from COVID-19 at this date stands at 159 deaths, and we extend our condolences to the members of those bereaved families. We have 84 new positive cases that would have been reported and correspond to tests conducted in the period of the 22nd to 24th of April. There are currently 134 patients hospitalized, and those are broken down as follows. There are 81 at the Couva Medical and Multi-Training Facility, 5 of them in ICU and 3 of them in HDU. There are 28 at the Cora Hospital, 25 at the Scarborough Regional Hospital at Fort King George. There are currently 237 individuals on state-supervised quarantine, and there are 9 persons in step-down facilities, all of them at the UE Debe facility. I'd like to continue with the next slide, which takes us straight into our epidemiologic update. As we can see, looking at the epidemic curve, moving from left to right, the left side of the curve representing everything from the end of July come forward to the end of the gray section in December 2020. That 2020 section is the section in gray. We then look at the colored sections for the months of January in green, February in blue, March in April, and the current March in orange, and the current month of April, which is in purple. And we look at that dotted line that's running through the background of the slide, which represents that 7-day rolling average, and we see that upward trend both in the dotted line and in the heights of the purple bars, indicating increasing numbers of cases steadily since basically the second week or so of March. Next slide, please. When we look at that, aggregating that same data on a weekly basis, we see the same color scheme, giving the gray bars for 2020, green ones for January, blue for February, orange. If we look at the orange bars, we start to see that steady increase in the heights of the orange bars. Weekly cases accumulate, And we see that we have one short bar for week 17, which really just represents the week that we're in right now. So that's not a completed week, but that is where we are to date for week 17. And the background of this slide, that salmon portion with the red line bordering it, gives us the percentage of tests that were returned as positive for COVID-19 out of all the tests that were performed, and that currently stands at 25% for week 16, and it just for the week 17 so far it's at 18%. So we see where that climb in the height of the orange section mirrors to some extent the climb in the numbers of cases. So as we're having more cases, we're also seeing higher rates of positivity, which indicate higher levels of circulation of the virus in the population at this point in time. Next slide, please. The demographics remain largely as they have been for the duration of the pandemic. We're looking at the male to female balance being slightly tipped in favor of men, with 53% of all the cases being diagnosed having been male, and the 25 to 49-year age group having the vast majority of the cases, with 55.4% of the cases belonging to that age group. Moving on to the fatalities, we see a different pattern in the next slide, where the persons who have passed on from COVID-19, next slide please, are actually distributed differently by gender, nearly 3/4 of them being men, and it's about 70% or so of them being in the over 60 age group. Also noting that the majority of those who would have passed on also had pre-existing conditions, chronic conditions, which included hypertension, diabetes, in some cases pre-existing cancer conditions that they were being treated for, kidney disease, other things that may have impaired their body's ability to respond to the virus. So that comorbidity profile was present for the majority of the people who had fatal outcomes. Next slide, please. As we're going to have a detailed geographic presentation, we're just going to mention very quickly here that compared with previous maps of this sort, we see a larger number of the communities being lit up, so to speak, and with deeper colors and larger numbers in that legend, showing that the communities with the largest numbers of cases are now showing between 16 and 25 cases, as opposed to previous versions of this map, where the largest numbers of cases may have ranged between 3 and 4 in February and maybe 6 and 7 in March. But we will have more of that descriptive and analytic geographic component from Mr. Siram Singh when he does the geographic presentation. Now, that brings me to the end of the epidemiological and the clinical update for this morning.
Thank you very much, Dr. Hines. Mr. Siram Singh will provide us with some additional information on GIS mapping as it applies to COVID-19 management. Mr. Siram Singh, good morning. Good morning. I think there's a challenge with the audio.
Good morning. Thank you very much.
Hearing you now. Yes.
Yes. Good morning, Dr. Hines, Suk Chan, Dr. Khan, Mr. Alexander, members of the media, and of course, members of the listening and viewing public this morning. Today, I will be presenting our GIS presentation for today. And as we move quickly across into this presentation, we begin by firstly taking a look at the spread of cases as we would have done last time, looking in this case at epidemiological weeks 12 and 13, which cover the period the 21st of March to the 3rd of April. And we note that back then, County Carney would have quite clearly recorded the highest number of cases at that point in time, with County Victoria following, and other counties such as St. George East, West, and St. Patrick also recording higher numbers of cases when compared to the previous weeks. We fast forward and take a look at epidemiological weeks 13 and 14, and again we see the County Victoria as well as counties St. George Central, East, West, and of course St. Patrick recording more and more cases, while County Carney remained generally around that same range of 50 per week. As we take a look at epidemiological weeks 15 and 14, however, covering the period 4th of April to the 17th of April, we note a change in this particular chart. As we know, the range changed from 0 to 50 to now 0 to 100, clearly representing that increase in cases, which we would have noted. And as we switch to our most recent map, which represents epidemiological weeks 15 and 16, covering the period 11th of April to the 24th of April 2021, I will point out at this point in time that epidemiological week 16's data is still being processed, and therefore this data set will not be a complete representation of the data recorded during that particular week. But what we note here quite clearly is that the spread of cases, when compared to the first map, which we looked at a short while ago, covering epidemiological weeks 12 and 13, we note this increased spread of cases. We see what is taking place in that St. George West to East region, where we are seeing more cases popping up in that area. But we note also in County River-Mayaro and St. Andrew St. David, though the numbers of cases are low there, what we are seeing is that in River-Mayaro, the cases are spread along the road network, so along the Naprima-Mayaro Road, all the way to Mayaro, and then down to Goyari, so where there's settlement taking place, or that takes place along the road networks, and of course in Sangre Grande and environs in St. Andrew St. David. Now, we use this data and we look at it slightly differently now, as we take a look back to epidemiological weeks 13 and 14 here. And as Dr. Hines would have mentioned previously, the highest range in this map, which represents a count of cases at the community level, would have been on about 7. And at that particular time, the San Francisco Penal area would have recorded the highest number of cases out of all the communities. However, as we fast forward and we look at epidemiological weeks 15 and 16, which again represents the period the 11th of April to the 24th of April, we note that the cases are spread across the entire country in counties across all of the in communities across all of the counties. We note now as well that the highest range in any of the counties, as we see here in the map, as we look at the legend, is 16 to 25, and we note those communities being in the St. George Central and St. George East counties. Of course, this increase in cases and the increased spread is in alignment with the increase in numbers which we have seen over the last few weeks. Taking a slightly different look now at the same data, we look here at epidemiological weeks 12 and 13. And we note that back then, the cases were primarily concentrated along the East-West corridor in that St. George West to St. George East area, and coming down into Carney, Victoria, and St. Patrick. However, as we look at the same data for the same type of map for epidemiological weeks 15 and 16, we note the increased spread with more areas being affected. But what we also note is that areas, even in those areas which previously recorded cases, we are seeing now that some of those areas are recording more cases. So it's not just about new areas recording cases, it's also about areas that previously recorded cases now recording more cases. Of course, we look at the legend and we see that the higher number of cases are represented in the orangish color, ranging from light orange to darkish, more reddish orange. And we know that the majority of those areas are in the St. George West to St. George East area, which of course is in alignment with the highly populated areas in that area. While there are other areas in County Carney and Victoria where they are scattered, where there are cases, but of course a few of those areas are scattered along those counties which record high number of cases as well. Using the same data, we look at our heat map, our density map, which shows quite clearly that the areas ranging from Diego Martin in St. George West down to Arima in St. George East, they have recorded among the highest densities of cases in the country. And of course, again, Chaguanas and surrounding areas in County Carney, as well as San Fernando and surrounding areas in Victoria, and Pinal and surrounding areas in St. Patrick were areas recording high densities of cases. That brings me to the end of the map components of today's presentation, but I will quickly mention again that we do have a GIS-based COVID-19 dashboard, which is available for the public to access. To access this, you can visit the Ministry of Health's website at health.gov.tt. You can click on the COVID-19 drop-down option and select Trinidad and Tobago COVID-19 dashboard. And with that, I come to the end of my presentation, so I hand over to Al, and I say thank you very much.
Thank you, Mr. Siram Singh. And we do invite the public to go on our website to get updated information. We now invite Nurse Grace Sukchan to provide an update on the progress of the COVID-19 vaccinations.
Thank you, Al. Good morning, Dr. Hines. Thank you, Al. Good morning, Dr. Hines, Dr. Khan, Mr. Siram Singh, and to you, the media, viewing, and listening public. We are now in the midst of Vaccination Week of the Americas. This year, it is being celebrated during the period April the 24th to the 30th. This year's theme is Vaccines Bring Us Closer, Get Vaxxed. Just to give you an update or a little background on Vaccination Week of the Americas. Vaccination Week of the Americas began in 2003 as part of the response to an endemic outbreak of measles in the Americas, which took place between Venezuela and Colombia in 2002. To prevent future such emergencies, the ministers of health of the Andean countries proposed the idea of a coordinated international initiative. Since its inception, the initiative has become a key driver of progress in immunization in the Americas and has given countries of the Americas a yearly opportunity to highlight the essential work of national immunization programs. The overarching objectives of Vaccination Week of the Americas are to promote equity and access to vaccination for people of all ages, regardless of where they live, leaving no one behind. Increase vaccination coverage of all antigens, raise awareness on how immunization saves lives, and to keep the topic on the political agenda. Promote the transition from child immunization to immunization throughout the life course. Serve as a platform for integrated public health activities. Vaccination Week in the Americas is a flexible initiative that has allowed it to adjust to challenging epidemiological situations such as the influenza A H1N1 pandemic in 2009 and the ongoing COVID-19 pandemic. World Immunization Week, celebrated in the last week of April, aims to promote the use of vaccines to protect people of all ages against diseases. Immunization saves millions of lives every year and is widely recognized as one of the world's most successful and cost-effective health interventions. Vaccination Week of the Americas and World Immunization Week are fully aligned with under the same slogan, Vaccines Bring Us Closer. This slogan will urge greater commitment around immunization globally to promote the importance of vaccination in bringing people together and improving the health and well-being of everyone, everywhere across the life course. The main goal of the campaign is to urge greater engagement around immunization globally and the importance of vaccination in improving health and well-being of everyone, everywhere throughout life. In particular, the objective of World Immunization Week 2021 will be to reframe the global debate on vaccines to focus on their importance, highlight the many ways in which vaccines enable us to lead healthy and productive lives by preventing the spread of vaccine-preventable diseases, demonstrate that the general public already values and trusts vaccines. This year's campaigns aim to build solidarity and trust in vaccination as a public good that saves lives and protects health. Trinidad and Tobago has always had a very robust immunization program. The Ministry of Health is currently spearheading the National COVID-19 Vaccine Deployment Program. Trinidad and Tobago received their first tranche of COVID vaccines from the COVAX facility on March the 31st, 2021. On April the 6th, 2021. The rollout of these vaccines started at 21 selected sites. The Ministry of Health, in collaboration with the Northwest Regional Health Authority, Eastern Regional Health Authority, Trinidad and Tobago Medical Association, and the Trinidad and Tobago Registered Nurses Association, operationalized 2 mass vaccination sites at the Paddock, Queen's Park Savannah, and Tacarigua Rocket Center to ramp up administration of vaccines from April 22nd to the 25th. A total of 8,759 persons were vaccinated at these 2 sites. The success of the rollout showed that we had a total of 38,638 persons vaccinated to date. The target high-risk exposure healthcare workers, persons 60 plus, and those over 60 with comorbidities. The immense success of the mass vaccination sites contributed significantly to vaccinated total figures. We continue to surpass projected daily uptake, which demonstrate the public confidence in the immunization program. It is a ministry initiative to operationalize more mass vaccination sites throughout Trinidad and Tobago to continue to provide excellent service to the general population. The RHA staff must be highly commended for their dedication and commitment to vaccinate the population. Our targets would not have been achieved without their unwavering support. The high vaccine acceptance generally across Trinidad and Tobago in this phase was phenomenal, and it suggests that Trinidadians and Tobagonians understand the importance of vaccination to save lives. We would like to thank all healthcare workers who continue to work together with the Ministry of Health. This collaboration emphasized the level of commitment and professionalism by the healthcare team and is reflected from the many positive feedbacks received from the general public on their experience at the vaccination sites. Vaccination under the National Immunization Program continues at all centers throughout Trinidad and Tobago. As we celebrate Vaccination Week of the Americas, you are urged to use this opportunity to get vaccinated against all vaccine-preventable diseases. We understand that the focus is on COVID-19 vaccines, but we want to remind the public that it is important that we continue to vaccinate against all our vaccine-preventable diseases. And please keep your clinic appointment to have yourselves and your family members vaccinated. If you are unsure of what vaccines is required for your children, we ask you to contact your nearest health facilities or call in to get your vaccination updated. I now hand you over to Dr. Hines, who will continue with the COVID-19 vaccination updates.
Okay, thank you, Ms. Sukhchand. That was an excellent and comprehensive summary. We just have a couple points to add or to make sure we underline or underscore. The first of those being that, as you would have noted, the initial receipt of the first batch or first tranche of those COVAX vaccines brought us in 33,600 doses of the vaccine. And at that point, with what was in hand, we set a target of half of that, so just about 16,800 or so, as the first group of individuals who would receive vaccines according to the priority list. During that time frame, however, as you would have noted, we then received additional donations of the vaccine, 40,000 from India, and added to the donation that had been received previously with the 2,000 from Barbados, we ended up with in excess of 75,000 doses, 75,600 doses at our disposal, and therefore the target for vaccination was extended. So we have exceeded that original target of 16,800, and as Ms. Sukhchand has pointed out, we have now vaccinated 38,638 individuals. Now, bearing in mind that we do need to keep doses in reserve for the second round of vaccination, so that everyone who has been vaccinated so far can receive their second dose of vaccines. we are beginning to wind down that first batch of vaccine distributions, bearing in mind and taking note that those who have confirmed appointments already for vaccines this week will still be accommodated. So the second round of vaccinations is due to begin on the 7th of June. This is the individuals who have already been vaccinated that will be scheduled to come back for their second dose of the vaccine to complete that vaccination event, that vaccination process. And we do want to encourage all those who would have received their first dose to make sure to present themselves as scheduled for their second dose so that you can complete the vaccination coverage and receive the full benefit of having been vaccinated. That basically brings me to the end of that additional summary for the vaccines. I'll turn you back over to Mr. Alexander.
Thank you very much, Dr. Hines and Nurse Sukchan. Next, we are quite pleased to have Dr. Khan, and she will offer some suggestions to cope with COVID-19 fatigue. Dr. Khan?
Thank you, Mr. Alexander. Good morning, colleagues, Dr. Hines, Mr. Siram Singh, Nurse Sukchan, members of the media, and all our viewers who are chiming in. Today, I would like to share some comments and tips on how best we can cope with the stressors and the psychological impact of this ongoing pandemic. So there is no doubt that this pandemic is taking a toll on many aspects of our lives. And as a nation, we have rallied over the past year to deal with the ever-changing picture and to adjust our behaviors and lifestyle to help prevent the spread of the virus. Now, many of us have been complying with the public health prevention measures, and this is commendable. Our health workers continue to provide yeoman service, and more so during the vaccine rollout. Now, many would have felt relief at the vaccine rollout and the hope that it poses for curbing the spread. However, the recent surge in cases is a sober reminder that the pandemic still poses a significant threat, and even if vaccinated, we all must remain vigilant in our efforts to combat it. We are facing heightened levels of stress, and stress affects both our physical health and our mental health, and it can also make us less likely to comply with safety behaviors. Accordingly, it is important for us to know how we can recognize the ongoing toll and how we can cope effectively to see it through. May I have the first slide, please? And the second as well. So at the University of the West Indies, my colleagues and I in the psychiatry unit are studying the psychological impact of the pandemic on the public. So we gave people a list of 25 issues and asked them to rate their level of concern for each. These included items like concerns about getting COVID, their job loss, paying bills, water supply, etc. And on the screen, you can see the top 5 concerns. As you can see, people are concerned about a number of things, including the economy, getting the virus, but also psychosocial aspects, managing their stress levels, dealing with reduced social contact, and getting accurate information. Next slide, please. Now, these kinds of concerns we have can affect our stress levels, and they also affect the behaviors we engage in. Let us look at how our behaviors may be affected by using a health behavior model, the theory of planned behavior. Now, this theory suggests that intention is the best predictor of behavior, and there are some factors that influence our attention. So these include our own attitudes, our perceptions of other people's attitudes, and also our belief in our personal control. Let's use a specific example to illustrate this. So the issue of avoiding crowds. So according to this model, you are more likely to actively avoid crowds if you believe that avoiding crowds will keep you and others safe, if you believe that there are many people you know who also think you shouldn't congregate, and also if you have the ability to avoid congregating. So for example, that you would say no to an invitation to an event if you found out that there were more than 5 people who were going to be there. Next slide, please. Let's look at another example of getting vaccinated. So getting vaccinated would be influenced by your belief that the vaccine will help keep you and others safe. It will also be influenced by whether you trust the experts who say that the vaccine is safe, and if people you know and whose opinions you value think that the vaccine is safe. It will also be affected by your ability and your knowledge about how to go about getting the vaccine. So, for example, when it's your turn, that you can go out and make an appointment. So our attitudes and the attitudes of others are critical in helping ensure that we engage in these health prevention measures. Next slide, please. Now, in our first study, we also asked people about their level of agreement with the various public health prevention measures. So as you can see in the table, in the top 5, agreement was highest for quarantining, hand washing, avoiding touching of the face, and closure of borders and schools. Now, this high level of agreement is a good sign. However, agreement was less for some other items, like avoiding crowds of more than 5 persons. And we have to be wary of this, because even a minority of persons who disagree might be less likely to comply, and this can pose a problem and become a threat to their safety and others' safety as well. So how do we combat this? Well, in this regard, we need to remind everyone what the expectations are and encourage everyone to abide by the measures. For half of these measures that you see, specifically items 8 to 14, men showed significantly less agreement. So we may need to reach out to the men in our lives and provide more encouragement to them as needed. Next slide. Now, one of the threats that's also influencing our attitudes is that posed by the current infodemic. An infodemic is a situation in which there's an overabundance of information, some of it accurate and some of it not. And this makes it hard for people to find trustworthy sources of reliable guidance when they need it. Infodemics are usually characterized by rumor, unsubstantiated information, stigma, and conspiracy theories. And it's made worse by social media like Facebook and WhatsApp, where reputable sources of information and news are competing with unreliable and untrustworthy sources. This is of concern because it affects public health and mental health at both the individual and the societal level. It fuels mistrust and fear and anxiety and panic and can lead to negative psychological outcomes. So we all need to limit our information to reputable and credible sources, the established news agencies and institutions, and refuse to share those information whose source you cannot verify. Next slide. Now we know, next slide please, we know that the mental health impact of the pandemic is also widely recognized. At this time, people are at higher risk for depression, anxiety, stress, and other mental health concerns. In our study of almost 1,000 adults, we found that 17% of persons were showing depression symptoms at levels requiring professional help. Next slide. We also asked people about their anxiety levels, and a higher number of people were affected by anxiety. So 26.7% of the sample were showing anxiety scores which also require clinical attention. Anxiety and depression were found to be higher in younger adults and less in older adults, and there was no difference between men and women. Next slide. So what we need to know is that we need to take control and exercise control where we have it to help us cope with the stressors. We need to find healthy outlets for stress relief that are in compliance with the public health regulations. So as families, as individuals, let us identify and plan safe opportunities for exercise, relaxation, fun, and social interaction to help us improve our mental health. Now, if you feel you need professional support, reach out. So there are different sources that you can go to find out where you can get help. The website www.findcareTT.com has a list of reliable sources of free help. You can also go to the Ministry of Health's website. And also recall that Dr. Othello, our Director of Mental Health, has also been providing guidance as to avenues that the public can turn to for support. So In wrapping up, let's be mindful and purposeful in our actions. If you're wearing a mask, wear it properly. Make sure it covers your nose and your chin and it's well fitting. Encourage your friends and family to stay vigilant. If you see them slipping up, remind them and encourage them to do better and to steady the course. We are still all in this together, and let us continue to be our brothers and sisters' keeper by doing what is needed to prevent the spread of the virus. Let us engage in active coping to manage our stress levels and ensure that we stay physically and mentally healthy. I want to reiterate the 3 W's that the ministry has been promoting. Wear your mask properly, wash your hands, and watch your distance. Stay safe and stay well. Back to you, Mr. Alexander.
And thank you, Dr. Khan, for very timely and relevant information and advice. As we move into our question and answer segment, a reminder to our media representatives to begin by stating your name and your media house before you put forward your questions to our panelists. Please remember no more than 2 brief questions at this time. If we do have time, we will take additional questions from you. We now go with CL Communications.
Good morning. This is Natalie from Caribbean Lifestyle Communications. I just wanted to find out, are there special centers for the disabled to go to in order to be vaccinated? And what are some of the guidelines that they should be looking at other than what we already know out there? And then 2, has a determination been made about whether or not the Brazilian variant is on community spread? Thank you.
Thank you for your 3 questions. Dr. Hines?
I'll turn the first question over to Ms. Sukhchand.
Thank you, Dr. Hines, and thank you for that question. So we have, as I mentioned earlier, 21 selected sites, and persons with disability or any challenges can go to those sites once they inform the security who would notify the staff inside. They would make arrangement to facilitate those persons without allowing them to wait long or, have any issues with accessing the vaccines.
Okay, thank you. And as for the second question, as you would have noted during the last release on the P1 variant, additional cases had been located or identified in areas that were neither, and in individuals that were neither geographically nor epidemiologically traceable or linked to the first one of the P1 variant cases that we identified a day or 2 prior. So while we cannot yet say that this is an established set of community spread, what we can say is that in the absence of geographic and epidemiologic links, we continue to monitor, but it is entirely possible that once the variant is introduced into the population, then it does what variants do, which is establish itself as one of the circulating strains. So we continue to monitor, and we will continue to keep the population updated as we get additional information, both on the testing and on the contact tracing.
Thank you very much, Dr. Hines and Ms. Sukhchand. We now go to AZP News.
Hi, good morning. Priya Bihari, azpnews.com. I don't know if Dr. Hines or maybe Sukhchand could answer this, but if we add up the 2,000 vaccines that we got from Barbados, the 33,600 from COVAX, and the 40,000 from India, and we divide it by 2, we get 37,800. And I see to date, we have already vaccinated 38,638. So is it that some people in the second tranche, when they go to get a second dose, they would not be able to get it? Can you just clarify that? And my second question, maybe Dr. Hines. Dr. Hines, it's been a while in terms of the same P1 strain. Why is it the ministry doesn't know exactly where the initial person and the other 3 persons contracted it? What is the key back in terms of that? What is the difficulty that the ministry is having in determining where did this strain come from? Thank you.
Thank you very much for your questions.
Okay, thank you. I'll actually take both questions. Now, with regard to the calculation done, I'm not sure if you remember, but what we did find when the vaccines were being distributed in the first place was that sometimes vials have what we call extra doses. There's additional volume within the vials that allows additional doses to be distributed. So that while you see that the number currently distributed exceeds the exact half, we do need to take into account that there are those additional doses that would have been distributed as a result of extra volume and as a result of not leaving any doses to waste, so to speak. So we still have the half of the received amount that will be kept in reserve for the second dose of vaccine. We don't expect to have any issues with regard to the availability of the vaccine at this point in time. And as we roll into that second half, we will keep you updated, but we expect that things will go according to the originally established plan. Now, with respect to the second question, I'm not sure exactly what difficulty you're referring to. We have given the information on the P1 variant with respect to the 4 cases that we have so far identified, the 4 cases being the one that was identified in Narova originally as our first detected variant, and then the other 3 in other parts of the country, indicating that there was no direct link between the first detected and the others. While at no point is it definite that we can say this individual contracted this variant in this particular area or in this particular interaction or encounter, there hasn't been any difficulty in stating that the variant itself is known to be a South American variant and therefore would be a variant that would have been introduced via that means. We don't know at which point the individuals who have been identified would have gotten their virus, because they're both national and non-nationals listed among those who are P1 positive. And as we continue to monitor and as we continue to do more of the contact tracing and get more information, we may be able to build a clearer picture. Bear in mind also that with the contact tracing, sometimes all the information that would be helpful in building that clearer picture isn't shared. So we can share only what we have received, we can explain only what we're aware of, and there hasn't been any difficulty to date in sharing or explaining the information that we have at our disposal. So maybe if there's time and another question comes back to you, you can clarify what difficulty you are referring to.
Thank you, Dr. Hines. Newsday, we are ready for your questions.
Hi, good morning. Paula Lindo here from the Newsday. I have quite a few questions, but I'll take my first 2. Could we get an update on public compliance with the recently implemented regulations? And Dr. Hines, you spoke about contact tracing just now. Have you been able to connect cases to exposure at beaches, restaurants, cinemas, religious institutions, performance spaces, etc.? And is there a way for the public or the media to be able to access those numbers? Thank you.
Thank you very much, Dr. Hines.
Okay, the first question was, just remind me.
Public compliance.
The public compliance, right. The reason that I had a problem is that we won't have any metric per se that gives us an idea or an indication of public compliance beyond observation. The observations so far indicate that there has been reduced movement in line with the existing implemented regulations, but we don't have a metric that says how well or not well that may be followed. We do, however, expect and we rely upon the protective services, TTPS, etc., to help to enforce where needed the regulations that separate individuals from congregating in public spaces. So it's sort of observational and anecdotal. We do see the decreased congregations anecdotally, but we don't have a specific metric that says whether that is successful or not. Now, the second question, with respect to contact tracing, yes, there has been in the past several, or there have been in the past several notes, several points at which we noted transmission in several of those settings, notably the indoor gatherings, notably the religious services. We don't find people necessarily stating that they went to a beach as part of the contact tracing information that is gathered. But what we do note within numbers is that when there are known large convocations at beaches, that the numbers go up significantly in a 2-week period thereafter. We've so far seen it definitively at least twice. Once when they were closing down the beaches for the and there was a quote-unquote last lap gathering that was followed a couple of weeks later by a spike that really could only be explained by an increased gathering 2 weeks prior. That it was outstanding the way that one particular spike stood out from the rest of the background data. And so too with the 2 weeks following the Easter period, that increase to relatively large numbers 2 weeks later again suggests that sort of correlation between convocations at those known gathering areas and the numbers that followed. Basically, we are aware that information on both our local and an international studies show that the indoor areas, the indoor air circulation poses a problem, poses an increased risk, and we don't necessarily have to wait for each case that we have seen to be linked to an indoor location to reduce the congregation in those areas, knowing there's an established risk. So while every case that we have doesn't necessarily link itself to one of those areas, we do know that there's an established increased risk. We have seen that pattern of increased cases after certain kinds of activities in the population, and our regulations, our attempts to reduce risk and reduce transmission mirror the mechanisms that would allow us to reduce contact probability by implementing the reductions in gatherings, etc., that you would have seen. So the short answer is yes, we've seen some of that supported by contact tracing. We've seen other bits of it supported by international evidence, and that is where and why we use the mechanisms that we've identified to reduce risk of spread. So I'm hoping that that is actually helpful.
Thank you very much, Dr. Hines. And I know that the TTPS National Security has been assisting where compliance is concerned. We now go to CNC3.
Morning, everyone. Rashad Khan, Guardian Media Limited. My first question is to Ms. Grace Sukhchan or Dr. Hines. I'm not sure who would be more able to respond to this, but with the minister's announcement that there has been some sort of confirmation of the Pfizer vaccine, or the possibility that it could be one of the vaccines we'll be getting in, what is the ministry's policy or stance on possibly mixing different types of vaccines? So for instance, getting the AstraZeneca as a first dose, and then getting something of a different nature like the Pfizer, which is mRNA, as a second dose. And my second question is also to both of you all. How is the ministry treating vaccinations and members of the socially displaced community? Are they able to get it? How are they being educated? And has anybody from that community received a vaccine as yet?
Okay, thank you. I'll take the first question. The mixing of vaccines is something that I believe we've addressed before. We have indicated that WHO has confirmed and has basically certified that the AstraZeneca vaccines that have been produced and that are being produced by the currently approved and emergency use licensed sites, that those are interchangeable. So that if you get an AstraZeneca vaccine from site A and then another one that comes from site B, among the confirmed and approved WHO sites, then those are interchangeable. But the mixing of different types of vaccines is not currently recommended. The different vaccines have different profiles in terms of how your immune system responds to them, and the WHO recommends that you stay within type for your vaccination first and second doses. Now, with respect to the second question on displaced communities or displaced individuals, I think I'll turn that over to Ms. Sukhchand.
Thank you, Dr. Hines, and thank you for that question. So with respect to socially displaced persons, if you would have remembered, our initial target population would have been, in phase 1, healthcare workers, persons 60 plus with chronic disease conditions, and then our essential frontline workers. So those persons are going to be part of the next phase, and we will be putting system in place to ensure those persons are vaccinated.
Thank you very much, Ms. Sukhchand. We now go to TV6. TV6, we are ready for your
Morning, Urvashi from TV6. My questions are for the Director of Epidemiology, Dr. Hines. Dr. Hines, are post-vaccine deaths and or adverse reactions reportable? If so, to whom and under what conditions? Secondly, the sequencing that would have picked up that first case of the P1 strain, did that come from a random sample? And that those cases having, well, that first case having now been discovered, going forward, are all positives now going to be sequenced to determine, well, if P1 is dominant and so on? Thank you.
Okay, thank you for the questions. At this point in time, the side effects or any additional adverse effects from a vaccinated individual can be reported to the site at which their vaccine was received. So there is in place an electronic platform that allows the capture of any significant sequelae that may turn up after a person is vaccinated. So you're encouraged, if you are experiencing anything that you consider to be out of the ordinary, that you can go back to the original site where you were vaccinated and share that information so that it is put into your record. So too for any additional more severe effects. Now, the sequencing that would have identified the P1 variant is still something that is being done largely under the auspices of the University of the West Indies in collaboration with the Ministry of Health, and random samples are being done to identify whether any variants of concern were in circulation. But that is still a relatively small proportion of the cases based on capacity. There are discussions in the background to have additional collaboration between Public Health England and the university to see whether additional capacity can be acquired. But at this point in time, with the existing capacity, we cannot test every single positive to identify whether variants of concern apply, whether a variant of concern is responsible for each positive. So at this point in time, the short answer to the second bit of your question is no, all positives cannot yet be tested for variants of concern, but the appropriate follow-up for those who have already been confirmed in terms of contact tracing and subsequent testing will shed some light on additional spread in addition to the current random sequencing that is being done. So that monitoring is going to help in determining the extent to which this variant establishes itself, but additional capacity still remains to be developed at this point in time.
Thank you, Dr. Hines. We quickly go to I-95.5.
Good morning, Whitfield Jenner from I-95.5. Dr. Khan, I'll start with you first. Do you have any concerns over the potential of creating a pandemic within a pandemic as it pertains to the public health measures and the impact that having to follow these measures over an extended period of time can have on a person's mental health? And my second question for Dr. Sukhchan or Dr. Hines, in terms of the elderly persons who are shut in, what are the plans for vaccinating those persons?
Thank you for your questions. Dr. Khan?
For the question. It asked about whether there might be a pandemic within a pandemic. Well, I think we need to look at how pandemics affect people. They don't just affect people medically. They take a toll on physical health and also mental health. So I think we need to be cognizant and aware of these risks, that with a global health pandemic, that it is going to pose additional stresses to people. And so we need to help people become aware of the toll it might take on them, to recognize the signs and symptoms, to equip them with the necessary coping skills that they need, and also that they know how to get professional help where they need it. So I think based on the guidance that has been provided today and in the previous press conferences, the aim is to help people become more aware of those stresses, the toll pandemics can take on our mental health, and where they can get help if they need to, and how to better make people be able to cope within their own environments.
Thank you very much.
Okay, I'll take the second question. Now, shut-ins and other such vulnerable groups will be part of the subsequent phases of the rollout as additional vaccine becomes available, and as the rollout is extended, then mechanisms will be engaged in the same way that they are currently accessed via the health system for other health interventions. Mechanisms will be engaged to ensure that shut-ins are also reached as subsequent phases of the vaccination rollout continue.
Okay, Express, we are ready for your questions now.
Kim Mudram from the Express. Thanks. My colleagues really took a lot of my questions, but Dr. Hines, I really have to ask you to revisit the variant issue. Urvashi just asked about testing for the variant. But from a layman's perspective, because that variant is causing a lot of buzz and concern in the national community. So when then might we begin testing all positive samples for that variant, and why wouldn't we do that? How then can we get an accurate representation of how prevalent it is in the national community, how fast it's spreading? I mean, I think the national community's concern is, as my other colleague said, a pandemic within a pandemic. So sorry, can we go back to that and say why we would not be testing all positive samples as soon as possible to see how quickly that's spreading? Also, to return to the vaccines, again, sorry, but some people are being given dates for their second doses later than the 12 weeks. And we know that, for instance, with the AstraZeneca, the efficacy has been shown to increase over the weeks and prevent hospitalization. But what is the reason, though, that some people who've gotten their first dose are being given a date that is a couple of weeks later than they initially recommended 12 weeks? If we could just clarify that. And does it have anything to do with expiry dates or the possibility that second doses may not be available at that time? Thanks. I hope that was clear.
Okay, thank you for your questions. The first question on why the testing of all positive cases can't be done at this point, I think, was already answered, and that was an issue of actual capacity. Additionally, what would normally be done in a situation like that is that you wouldn't necessarily test all of the positives, but you would look at getting representative samples of the 1 in how many ever, 1 in 10, 1 in 20, 1 in something of the positives to get an idea of the distribution across geographic and other lines, so that we get an idea of where these cases may be popping up, even though you may not test every single individual. So it isn't necessary, it isn't absolutely essential that every single positive be tested in order to get an idea of how established the variant may be. There are other sampling methodologies and strategies that would be employed to make the best use of resources while still getting the best and most useful information on geographic distribution. So within the capacity that we currently have, we continue to do that, and as additional capacity becomes available, then that testing will be quote-unquote ramped up. Now, the vaccination dates issue, to some extent, the vaccination dates are going to vary between the 8 and the 12-week marker, as I know we had indicated previously. And the dates are going to be, to another extent, limited by the point at which the expiration date comes up. So you will find that some may be shorter and some may be longer, but none will necessarily exceed the 12 weeks. Some may be down to the 8-week time frame, as the scheduling is done in such a way that we optimize the time between one dose and the next, while still remaining within the viability of the batch of vaccines that is currently available. So variations may occur depending on a number of things, but rest assured that the scheduling will be done in such a way that all the second doses are delivered prior to that expiry date, and that the optimal spacing between first and second dose is ensured for each candidate who is vaccinated.
Thank you very much, Dr. Hines. We have come to the end of our question and answer segment. Thank you for joining us for today's media conference. We really do appreciate that you take the time each week to attend these conferences. Remember, we are all in this together. Thank you and be safe. Remember the 3 W's. Goodbye for now.